Hello, this is Jessie from Group 13, and today our presentation is on rhabdomyolysis. The objectives for this presentation will be to introduce a patient case, describe the pathophysiology, risk factors, etiology, and complications of rhabdomyolysis, discuss the signs, symptoms, and diagnostic criteria for rhabdomyolysis, review the pharmacologic treatment options for rhabdomyolysis, and finally, design a treatment plan for a patient case. BC is a 27-year-old male who presents to the ER for evaluation of sudden onset abdominal muscle soreness. The event started 3 days ago after completing sit-ups. Patient is experiencing abdominal edema that is spreading to his scrotum. He reports associated symptoms of dark-colored urine. The patient does not have any past medical history. He denies alcohol and tobacco use. He has no family history of relevance, and he has no known drug allergies. His blood pressure is 97/58. His heart rate is 85. And his respiratory rate is 18. His O2 set is 100%. For home medication, he is just taking energy supplements. For our patient's labs, his CPK is extremely elevated, which indicates there is muscle damage. His hemoglobin is elevated. His AST and his ALT are also very high, and his serum creatinine is slightly elevated at 1.4. For his urinalysis, it is yellow, clear, positive for protein, negative for glucose, and all other is negative for no growth. The CT of his groin is diffusely thickened scrotum, which may reflect underlying scrotal edema and/or cellulitis. Hyperemia of the right testicle may reflect also underlying inflammation and a small bilateral cyst. His blood at this time is still no growth.
So now we will get into what exactly rhabdomyolysis is. And what it is the breakdown of the skeletal muscle cells, which basically leads to the release of the myocyte contents into the blood. It's characterized by a classic triad which includes muscle pains, generalized weakness, and a dark urine color. So although there are numerous causes of rhabdomyolysis, there is one final common pathway that rhabdomyolysis goes through. First is the depletion of ATP, which is basically the cell's energy source. This causes an increase in intracellular calcium in the cytoplasm and the mitochondria. The increase in the intracellular calcium then causes an activation of proteases and the generation of reactive oxygen species, which ultimately leads to the skeletal muscle cell death. Overall, the depletion of the ATP causes a dysfunction in the sodium-potassium ATPase and the calcium ATPase pumps that are essential in maintaining the integrity of the myocyte. The injury to the myocyte causes the release of the cell's inner contents into the bloodstream, which includes creatinine kinase, various muscle enzymes, myoglobin, and electrolytes. Ultimately, the release of large amounts of myoglobin into the circulation leads to the myoglobin levels exceeding the protein binding of haptoglobin, which can precipitate in the glomerular filtration, which basically causes renal tubular obstruction, nephrotoxicity from ischemia, and can lead to acute kidney injury. With regards to epidemiology, rhabdomyolysis is most common in adults. It can occur in the pediatric population, but it just isn't as common. There are approximately 26,000 cases of rhabdomyolysis each year, with the majority of the cases having multiple causative factors. And one study out of the Journal of Medicine actually found that 24% of cocaine-related conditions experience rhabdomyolysis.
There are three main etiological causes of rhabdomyolysis. Hypoxia, resulting from reduced blood flow or oxygen transport, leads to cell death. Causes of this include carbon monoxide or cyanide exposure, vascular compression, sickle cell crisis, thrombosis, and vasculitis. There are also physical causes, those that deal direct damage to the skeletal muscle cells, resulting in leakage of cellular contents. This includes trauma, such as crash or injury, burns, hyperthermia, and seizures. Finally, there are chemical agents that lead to the damage of muscle cells. Examples include internal electrolyte abnormalities, organic toxins, statins, stimulants, alcohol, illicit drugs, antipsychotics, lithium, and antihistamines. Rhabdomyolysis is diagnosed via an assessment of risk factors, a thorough history and physical examination, and laboratory testing. Lab markers that may indicate rhabdomyolysis include a CPK elevation increased serum creatinine, a BUN to creatinine ratio of less than 10 to 1, elevated BAC, and positive urine drug screening. There are also electrolyte imbalances that are associated with rhabdomyolysis. This includes an increase or decrease in serum phosphorus, an increase or decrease in serum potassium, and decreased serum calcium.
The three problems our patient is facing is the prevention of acute kidney injury secondary to muscle breakdown or rhabdomyolysis, the accompanying pain, and the management of that pain, as well as deep vein thrombosis prophylaxis. The first problem our patient is facing is the potential onset of acute kidney injury secondary to rhabdomyolysis. The patient presented with abdominal soreness and swelling after intense exercise and also reported dark-colored urine characteristic of rhabdomyolysis. Further evaluation showed transaminitis along with a creatinine phosphokinase value of greater than 22,000. The patient's BUN was normal, however the serum creatinine was slightly elevated at 1.4 milligrams per deciliter. Goals for this patient are to avoid acute kidney injury and the accompanying fluid overload, electrolyte abnormalities, and acid-base disorders that are accompanied with diminished renal function. In order to prevent these complications, it is recommended the patient begin receiving fluids to ensure kidney perfusion. Our plan for this patient is to initiate 0.9% normal saline at 200 milliliters per hour with a goal of approximately 10 liters a day to prevent AKI. If the patient experiences drastically worsening renal function, dialysis may be necessary to prevent fluid overload, electrolyte abnormalities, and acid-base disorders. The patient should be monitored daily for urine output with a goal of 200 to 300 milliliters per hour, as well as a BMP, calcium, serum creatinine, and BUN to ensure proper renal function. The second problem for this patient is the management of the patient's pain. Upon arrival, the patient reported experiencing intense abdominal pain. Because proper pain control is accompanied with better patient outcomes, the patient should first be assessed for his level of pain, using patient self-report as the gold standard. A pain protocol should be initiated to provide analgesics based on the severity of the pain, with acetaminophen used for mild pain and opioids for moderate and severe pain. If utilizing opioids for pain control, the patient should be started on a bowel regimen of Docusate and Senate by mouth twice daily to ensure bowel movements. Monitoring should include pain relief and respiratory rate in the case of the use of opioids. The patient should be followed up hourly for adequate pain control and to ensure that respirations remain above 12 breaths per minute.
The third problem that we're going to address is the need for deep vein thrombosis prophylaxis. This patient is at increased risk for deep vein thrombosis due to his current immobility. The goal is to prevent the formation of these DVT blood clots. Patient may need pharmacologic anticoagulation to prevent DVT formation until the patient can ambulate. The plan is to initiate Lovenox or enoxaparin 40 milligrams subcutaneous daily per the 2012 CHEST guidelines. We're going to monitor for signs of bleeding as well as signs of clot formation. Follow-up will be daily until the patient begins ambulating with physical therapy.
We have put together a few questions to finish up this case. Question 1. Which of the following are potential causes of rhabdomyolysis? Illicit drug or alcohol abuse, trauma, infection, medications, or exercise? If you selected F, all of the above, you are correct. Illicit drugs including cocaine and heroin, alcohol abuse, trauma, recent car accidents, infections both viral and bacterial, medications, specifically statins, and excessive exercise can all damage muscle and cause rhabdomyolysis. True or false? The pH of urine in patients with rhabdomyolysis increases or becomes more basic. The answer is false. Patients with rhabdomyolysis can present with a marked decrease or acidic pH. In our case, it was mildly acidic at a 7.0, but can become even more acidic. Elevated serum creatinine kinase levels is a gold standard for definitive diagnosis of rhabdo. How long after trauma would you expect to see a peak in serum levels? 12 to 24 hours, 4 to 5 days, 6 to 8 hours, 1 to 3 days, or more than 5 days before peak levels? The answer is 1 to 3 days. CK levels do rise within 12 hours of muscle injury and peaks within 1 to 3 days and has about a half-life of a day and a half. So this is why it's important to continue to monitor serum levels during treatment to make sure that there's no ongoing muscle injury. Our final question is, what levels of CPK elevation would the risk of kidney injury be most concerning? The answer is D, greater than 5,000 units per liter. A is typically 5 to 10 times the upper limit of normal, which is used to confirm rhabdo. 2,000, we're not so much concerned about kidney function at that point. 10,000 is, yes, a high number, but typically we want to start looking at kidney function above 5,000 units.
Great job on the quiz, everyone. Now I'd like to wrap up the case with our plan for discharge counseling. We want to counsel the patient on what led to his rhabdomyolysis and ultimately hospitalization. I also want to counsel for signs and symptoms that he should seek medical attention for in the future. I talked to the patient about how his condition was most likely brought on by excessive exercise and potentially exacerbated by his nutritional supplement use, and counsel the patient on the importance of exercising in moderation and in discontinuation of further supplement use unless recommended or prescribed by a doctor. We'd like to emphasize in this counseling session that he should drink plenty of fluids, especially when exercising, working in hot, humid weather. He should seek medical attention in the future if he notices a significant decrease in the amount of urination or frequency of urination. If he notices any urine color changes, this can be brown or dark tea colored, or pink, can indicate blood in the urine. If, especially after exercise, he notices pain, weakness, or swelling in the arms or legs that doesn't go away, he should seek medical attention. These are our references. Thank you. What questions do you have?